Good afternoon. And today we have a very special guest. It's the physical therapist who specializes in the orofacial pain. And it's only 60 of people like Karen Cote in the world. So I'm very honored to present Carol to my audience. And again, thank you very much for listening. We appreciate you so much. If you have trouble sleeping or sleep next to the snoring partner, please click the like and share button. This way you can help people who you love to spread the word, and you can help us significantly. And if you're a medical professional who are passionate about helping people sleep and breathe better, please use my channel as a networking ground, because only together we can connect all the dots, find the root cause of this disease of evolution, and help our patients live happier and healthier life. So again, good afternoon, Carol.
Yeah, thank you, Maria, for having me on your presentation. We do share the same goals in helping people get out of pain, improve their quality of life. And of course, sleep is the sixth vital sound, so important, and is such a measure of health and so valuable. So I appreciate the opportunity of speaking with you today. And hopefully we'll have better, collaboration, because we all, as a physical therapist, we all work with the same goal, with the patient in mind. So working with dentists like you. Thank you for allowing me.
I would like to give a short presentation about Carol. Carol been in the field for more than 40 years, but her specialty is so unique because she took a lot of courses to be really knowledgeable about the dental field, including the Dawson course. I also graduated from the Dr. Dawson program, and I'm eternally thankful for that knowledge. It really shaped me as a specialist so much. And she did a lot of courses, including international courses in China on acupuncture, really helped people who suffer from chronic pain. And one of the passion of Carol, what brought us together, what she worked in collaboration with the dentist to help their patients to get rid of pain, because chronic pain can be really frustrating for provider as well as for the patient. She attended a lot of dental conferences, which I find so unique for somebody who is not a dentist, go to dental conferences and understand what language we actually speak and what we are passionate about, and how why do we have such a tunnel vision? In my program, I'm trying to create collaboration between different specialties, because we're not headless horsemen. We actually have head connected to the body and teeth, reflecting a lot of things what happen outside of the mouth. But that's why my first question to you, why physical therapist is a key member of a collaborative team who can help to resolve not odontalgic or not the tooth pain, but it feels like a tooth pain.
Yes. Yeah.
Why?
Yeah. Why should a physical therapist, we understand things collaboratively. Our strategies work very arm in arm with what you as dentists do. We assess, again, the muscles, the jaw, the cervical spine, how people breathe. We also, very importantly, have strategies such as myofascial release, dry needling, craniosacral therapy, and again, myofunctional therapy is in our training. And of course, the end all, exercise, teaching people how to move smarter, not harder. And it totally collaborates with you, the dentist, and even, doctors, neurologists, getting people out of pain and addressing the root cause. Yes.
Very important. I got a lot of questions, and I'm actually going to do presentation this weekend on a Renaissance Weekend Conference about fascia. So I would like to ask you, what exactly is myofascial release, and why fascia is important, and why fascia get tight, and why actually diaphragm, which is our core muscle, get tight?
Yes, yeah. Fascia is the non-contractile. It's the tensile force within the muscle. There's 3 layers of fascia. There's the epimysium, perimysium, endomysium. 3 layers of fascia within the muscle. And there are mechanoreceptors, muscle spindles are in muscles. That's very, very important to give you proprioception, movement activation, sensation, position, space. And so, but it is also gives you that feedback of how muscles work. Myofascial tightness is that when you get thickening or tightness of the connective tissue from muscles not being able to let go. And so there's a big connection there with muscles and the autonomic nervous system, which has you brace versus or elevated sympathetic drive, or the somatic system, the muscle control. So people with myofascial pain have lost somatic ability to let go muscles. So they can't let go. So that's part of myofascial pain. And so
what do you do when you do release?
With myofascial release, it's hands-on. There's so many different techniques, and actually different techniques for different patients as well. Not the same, but you're actually working the superficial tissues as well as working into the layers. And also, I like to introduce this concept of active release therapy, where you're using an opposite muscle to let go a tense muscle that won't let go. So it's called active release therapy. And in addition, it's not just myofascial release, because if it's passive, it's temporary. Get the brain involved, get the patient's brain involved, more sustained. So, and then and with the core, with the goal being core strengthening, the muscles that really hold you up against gravity. So that's what myofascial release, but it's part of the answer.
I would like to ask you about our favorite book of my favorite friend, Dr. Steven Lambert. I know you have that book and I have that book, and we interview Steven on our channel. And I would like to ask you why do you think that book is important? You know, treat cause, treat the airway. Why is that book important for physical therapists?
Well, I share the same idea, perspective as Dr. Lambert, because the body will do whatever it takes to breathe. And breathing is part of the autonomic. So again, there's sympathetic drive, or the bracing response. And so he goes into, how the body, how airway impacts the different organs. I specialize in how elevated sympathetic drive drives soft tissue pain, mechanical and musculoskeletal pain. So
I would like to ask you.
So we collaborate. We have the same idea.
Excellent. Who are the patients who would benefit from being referred to physical therapists? And I want to ask you specifically, very frustrating. We evaluate the patient. We send the patient to endodontist, and patient said, this tooth hurts. This tooth hurts. I can't sleep. It's driving me crazy. Last week, this tooth hurt, and it also was driving me crazy. And we send you to endodontist, and the endodontist check this tooth and all these teeth and say, nothing. I don't see any problems. And patient said, I'm crying. I'm dying from pain. So tell me, who are the patients why it can happen, how physical therapists can help? And I think I have a good examples. We can share the slides with the audience and you can explain.
Who are the patients that would do well is obviously complicated cases that have, complicated cases, chronic recurrent pain. One of the case studies that I've worked with is muscles can refer to teeth. So muscles and sinus are the two things. So I've had people have had their teeth pulled, unnecessarily because they had the tooth pulled, they still had their tooth pain because their pain came from their muscle. And muscles can refer pain to teeth. And so, you know, anybody listening to this workshop, if you have a person with tooth pain and you're not sure about it and you send them to the endodontist, and the endodontist assessment is inconclusive or not odontal refer that patient to a physical therapist where we assess and also that is definitely referral to a physical therapist because we have many tools in our toolbox. You know, myofascial release, key exercises, neuromuscular, craniosacral, dry needling, to assist you with your patient getting out of that TMJ pain. So, and of course, if they cannot tolerate the appliance, then there's also an airway component, and we can be addressing that as well, because that involves the oropharynx and the cervical spine.
I would like to bring this specific patient on a screen, and I would like you to talk about this patient. If you can give us some, you know, situation, what happened with her, yes, and why, how can you help her? If she looked like a typical patient who suffer.
Yeah, Brenda is a 24-year-old that started having jaw pain when she was 15. Most significant, though, is that she had 4 years of orthodontics. So she had a palate expander before and then 4 years of orthodontics. And in her case, she started having the right jaw pain when the braces got removed. And then she was kind of bearing with it. But in her case, what actually ended up happening, she came to me through word of mouth, is that I was able to identify that she had she has a class 2 facial profile. She had a class 1 occlusion, which was mocked by the orthodontics. However, she still had a severe airway issue. So when she brought her tongue back to her tonsils, and she did a head nod, she couldn't breathe. Her oral pharynx was very restricted, and which is why the braces didn't really work as well with her jaw. So, and of course she had some morning fatigue, and you can see the photo of her. She had the dark circles under the eyes. And so when I got her how to strengthen her tongue, relax her throat, release hyoids, work with her posture, and improve her airway, correcting diaphragmatic breathing. You see the 2 photos on the left was her before, and then the one on the right was actually just after 5 sessions that we did over a 6-week time. And but because of the oropharynx weakness, she still had the forward head. So I referred her to a colleague who was an airway dentist for his assessment, because she'd never been assessed for her airway, never been assessed for sleep, never never had any of that workup. So and that's where we are right now, is that and I'm awaiting the results from her dentist.
Excellent. Tell me, what role does airway and tongue play to contribute to orofacial pain and TMD pain?
Airway is king. Your body will do whatever it takes to breathe, including putting up with pain, and clench and brace. You're going to do whatever it takes. And it's like blinking. It's within voluntary control, but it's more automatic. So clenching, so tongue needs to be in charge of the mouth, not only the tip of the tongue, but the tongue base. And when I say tongue base, I'm talking about the ability to do velar voice stuff, la, la, to open up the oral pharynx, and to be able to stick the Malampati score of a 1. So stick the tongue out, pointing right, left, that's tip, and then ability to tongue forward and open up the airway. So the tongue needs to be in charge of the mouth, step 1. And then, and I use the tongue to let go the muscles that clench. If you're just kind of watching and you try to push your tongue into your teeth, you're gonna feel with your hands how your muscles brace. So the tongue is in charge. So that'll brace. So stop chasing symptoms, tight muscles, jaw pain, and let's get to the root cause. And that's tongue and airway.
That's wonderful. We also preach exactly to the same guts, and we're talking about a tongue on the spot all day long. But it's very hard, I think, in our day and time to get to get this message across. But we're both trying. Can you please share to us why people clench their teeth? What do you find it from? Gravity, standing straight? Why people clench?
Yeah, clenching is a reflex, like blinking. Okay, it's a protective reflex, and I call it. I really believe it's related to restricted airway. It's an inefficient way to maintain that oropharynx opening. Also, clenching occurs when there's elevated sympathetic drive, like stress. And also it's part of the habits. People are blind to habits, and they've developed that habit. They go into muscle memory of clenching, and they don't know where to put their tongues. So that's part of that whole response, that why people clench. So it's
tell me, because we are about sleep, how sleep quality affect level of pain. What do you see in your practice, and how can you explain role of physical therapist in addressing sleep-related questions?
Oh, well, sleep is, in my opinion, is the sixth vital sign. People with lack of sleep have central sensitization, low pain thresholds. And so they're much more sensitive to pain. Muscles don't let go. You have accumulation of pain-producing chemicals in the muscles. Muscles can't relax. You got to rest. They're not into rest and repair. Of course, let's not get into the whole cognitive side of that and energy fatigue. But sleep is huge. And again, the whole endorphin component, as well as the gut. There's so much involved that sleep takes care of, and you got to clean out your brain. Sleeping is so important to clean out the waste products of the brain while you're awake. So it's important.
Please tell me, in your practice, do you see the connection between orofacial pain or clenching and then pain in the other parts of the body? I'm talking about shoulder pain, tightness in the neck, in herniated disc in a lot of people, and
yes,
inability for people
yes,
to stand for a long time, or pain in the feet.
Right. Yes, very much so, because the anti-gravity system. And actually the anti-gravity system, let me bring this, as you as dentists look at from the head up, kind of looking at the jaw, but there is some work that's done out there with the big toe balance, the manubrium, the zygoma, in terms of balance and posture. Gravity is huge, balancing the body. And so when you're off, the body works harder. So there's that muscle overwork predisposes you to myofascial pain and muscle memory, all of that holding patterns. Also is that there's a whole connection with foredead posturing to maintain airway, which actually exposes people to cervical radiculopathies, disc herniations, and of course, forward head posture, again, predisposed with class 2 facial profiles, excessive. And then on that video, on that slide, you can see, again, the cumulative degenerative changes from severe imbalances of the neck and the jaw driven by airway.
I have several questions. Tell me, what about tightness of the diaphragm? A lot of people don't breathe all the way to the stomach.
Yes.
They breathe in the chest or maybe in the neck.
Yes.
Breathe really fast, superficial, because, life is staccato now.
Yes, yes. And again, the superficial hyperventilation, which goes into neck and chest breathing and not fully engaging the diaphragm. Now, as a physical therapist, I'm glad you asked this question, because there's a connection of the diaphragm to the pelvic floor. And that is what physical therapists do. And the diaphragm needs to be released, ribs needs to be expanded, while again, pelvic floor needs to, they need to move, together. And so as you take a deep belly breath, lowering that diaphragm, pelvic floor is involved, as well as rib expansion. And when there's stress or pain, people tend to do the shallow hyperventilation, which is part of elevated sympathetic drive, fight, flight, freeze response. So again, the diaphragmatic breathing, rib expansion is so important. And that also feeds into core strength. So yes. It's a very loaded question, but
yes,
therapists, we work from the toe all the way up to the top of the head. We don't stop at the neck. So that's how we can help you, the dentist, because we look at things in a different way.
Yeah, no, it's absolutely fascinating how all of it connected from tongue to toe. And I would like to ask you practical questions. Please share with us what practical tips you can recommend to our audience to decrease the pain in the jaw joint, and recommendation for stretches, for self-massage, for exercises, for compresses.
Well, first of all, it starts with airway, and you got to put your hands on your neck. Make sure you're not using your hyoid, your scalenes, or your chest to breathe. You should only be doing diaphragmatic breathing. Once you've mastered that, the next step is doing what I call the tongue positioning. It's a tongue cave where you suction. You know how you cluck? Well, what you do is you suction, but you don't cluck. Okay, and that resting tongue, now take away the suction, rest that tongue up there, and then with the tongue up there, slowly relax the jaw, open jaw down and back without bracing the hyoids. Now you're getting your tongue to let go of your masseters. That's a neuromuscular strategy. Now, it's kind of hard in this setting to explain it, but when you're in the office, you got a patient lying down and they're figuring it out, it's game-changing, because I always have them, it's a neuromuscular control where I use the tongue to let go the masseters. And it's better than Botox because it's sustained. They learn it. People feel better with what we do. They get better with what they do. We're the coaches, so they do it themselves. So no recurrent Botox injections is what I find. However, I will say my opinion about Botox, there's a place for Botox. So that's where we need to collaborate.
Absolutely.
Therapy. Yes.
Yeah. What about dry needling?
Absolutely. Dry needling in the masseters, the medial pterygoids, critical. Temporalis. It depends on the presentation. Everybody is unique, one of a kind. And dry needling is also a tremendous strategy to resolve the knots, the taut bands. And there are different ways with electrical stim, leaving the needles in. It actually stimulates serotonin. So the dachi, the initial using needles stimulates endorphins, but when you do it with electrical stim on a time base, it facilitates the rest and repair, sympathetic, parasympathetic with serotonin release. And people just like, oh my God, I can't believe, they just walk away in disbelief how they can relax muscles. Wow. So it's really, anybody listening, it really should be tried first with the exercise, in my opinion, because you don't have to have repeat injections and you're not paralyzing those muscles. You're teaching them how to work. So, and airway is king. So it always goes back to the myofunctional, but also releasing hyoids, releasing cervical spine, how you hold your head up to see, head writing reflexes, and breathing. So those are all the priorities that impacts muscles of the jaw.
Thank you very much, Carol. We really appreciate your time and such valuable information. And thank you.
Oh, it's a pleasure. Thank you for allowing me to speak and share my information. And if anybody has any questions, or they can feel free to contact me. And you're going to have my information.
Yes, we're going to put information about the society for people who don't live in New Jersey but have orofacial pain and want to find certified therapists who treat.
Yes, yeah.
Yes, we're going to put a link for that under the interview, and your contact information, that people can find you. Thank you very much.
Thank you.